Lateral epicondylitis presents a frustrating clinical reality. While over 80% of cases are managed without surgery, localized treatments often result in recurrent failure. We see the tissue fraying here at the lateral epicondyle, but targeting this specific point rarely resolves why it started tearing in the first place. The physical breakdown occurs within the tendon of the extensor carpi radialis brevis, or ECRB. This tissue is the site of the damage, but it is not the source. It is merely the point where the cumulative structural strain finally exceeds capacity. Localized elbow pain is the distal symptom of a systemic force failure occurring much higher up the upper extremity. To find the root, we have to trace the mechanics backward. The failure begins in the cervical spine and the shoulder, initiating a proximal-to-distal compensatory cascade that eventually overwhelms the forearm. This deconstruction will map the biomechanical drivers of that cascade, differentiate local tissue degeneration from neurological referral, and establish a systemic rehabilitation framework for long-term resolution. Permanent recovery requires moving past the isolated elbow model to treat the entire arm as a single interdependent kinetic chain. The ECRB has two primary mechanical roles. It must stabilize the wrist in an extended position and act as a structural anchor, preventing the wrist flexors from pulling the joint into flexion during a heavy grip. This diagram illustrates the ECRB's structural disadvantage. Originating close to the elbow's pivot point, it has a short moment arm compared to the forearm's long lever. This lack of leverage requires the ECRB to generate massive internal tension to counteract external forces at the hand. When the body cannot keep up with this tension, the result is angiofibroblastic hyperplasia, better known as tendinosis. This is a degenerative state, not an acute inflammatory tendinitis. Under the microscope, we see the structural shift. Healthy, parallel type 1 collagen fibers, which handle high tensile loads, are replaced by disorganized type 3 collagen. This new tissue is weaker, less elastic, and prone to ongoing failure under normal mechanical stress. The driver of this cellular decay is repetitive eccentric overload. This occurs when the ECRB is forced to lengthen while it is trying to contract, such as during sudden wrist flexion or deviation under load. The anatomy creates a second point of failure. As the elbow straightens, the ECRB tendon's deep surface is compressed and dragged across the bony lateral capitellum, adding mechanical abrasion to the existing strain. The tendon is caught in a cycle of mechanical disadvantage and structural abrasion, leading to a state of chronic cellular degeneration. Most manual tasks occur on a horizontal working plane, typing, driving, or using tools. These activities require a pronated hand position, with the palms facing downward toward the floor. A forward head shift creates a thoracic curve that forces the shoulder blade to tilt anteriorly. The humerus follows, internally rotating the palm backward. To flatten the hand for tasks, the brain forces extreme forearm pronation, tightly twisting the radius over the ulna. This compensatory twist creates a passive bowstring effect. Because the ECRB anchors on the lateral elbow, this forced forearm rotation pulls the muscle taut. Its microscopic contracting units, the sarcomeres, are pulled too far apart. This elongation destroys the muscle's optimal length-tension relationship. An overstretched muscle cannot generate force efficiently. To compensate for this functional weakness, the body initiates grip over activity. You are forced to squeeze objects much harder than necessary to achieve joint stability. The ECRB fails because it is trapped in a biomechanical bottleneck, forced to pull around a corner to make up for a shoulder that has rolled inward. The cervical spine acts as the structural anchor for the shoulder and the electrical root system for the nerves of the elbow. The nerves controlling the ECRB originate in the lower neck. The C6 and C7 nerve roots exit the spine and blend into the radial nerve, which provides the electrical signal for wrist extension. Postural compression in the neck can cause a first crush. This is often asymptomatic, but it restricts axoplasmic flow, the nerve's internal transport system. This makes the entire nerve length chemically fragile and hypersensitive. When that fragile nerve reaches the elbow, ordinary mechanical stress becomes the second crush. This tap-in point creates severe pain and accelerates tissue breakdown. In many cases, the elbow tissue isn't the problem at all. A bulging disc at the C6 level can project a burning ache onto the lateral elbow via referred pain, perfectly mimicking the symptoms of tennis elbow. If a clinician misses this neurological anchor in the neck, they are treating the symptom of a choked nerve, which guarantees the pain will return. Effective rehabilitation requires a dual-track approach, settling the acute local pain while simultaneously re-engineering the proximal alignment. Phase 1 utilizes local defacilitation. Dry needling into the ECRB muscle belly and supinator resets the muscle spindles and calms the neurological hypersensitivity traveling to the spinal cord. Manual techniques like mobilization with movement are used to rapidly reset joint tracking at the elbow, creating a window of pain-free movement. We then move into Phase 2, load tolerance. This shift moves away from passive treatments and toward progressive tendon loading. We use isometric holds for immediate pain inhibition and progress to slow, heavy eccentric loading. This eccentric load is the catalyst for repair. It physically forces the body to remodel the disorganized type 3 collagen back into load-bearing parallel type 1 fibers. At the same time, we initiate proximal realignment. Strengthening the lower trapezius and serratus anterior pulls the shoulder blade out of its anterior tilt and back into a stable posterior position. Finally, strengthening the infraspinatus pulls the humerus into external rotation, physically reversing the internal twist of the arm. While these phases rebuild the tissue and resolve the pain, the kinetic chain must still be integrated for functional, real-world tasks. In Phase 3, functional integration, isolated forearm exercises are discontinued. The goal is to ensure the forearm never has to work in isolation again. We transition to global movements demanding force transmission from the ground up. This single arm row transfers energy from the core directly into the hand. This retrains grip dominance. When the hand closes, the scapular retractors must fire simultaneously to absorb the shock of the movement. Braces and ice provide temporary relief, but they do not change the structural environment. They are local responses to a systemic problem. True resolution of lateral epicondylitis only occurs when the forearm is freed from its compensatory twist. By restoring the neck and shoulder, we return the burden of force to the large muscles of the kinetic chain, where it was designed to be handled.